Okay, so this is number second video of the malignant melanoma. So, and these are the very important genetic subtypes. These molecular subtypes are based on the distinct genetic changes of the melanoma cells and mutations. These genetic changes include a BRAF mutation. The most common genetic change in melanoma is found in the BRAF gene, which is mutated in about 50% of cutaneous melanomas. And NRAS mutation. NRAS is mutated in the tumors of around 20% of patients with melanoma, and NF1 mutation are present in the tumors of around 10 to 15% of patients with melanoma. KIT mutation. These mutations occur more commonly in melanomas that develop from mucous membranes. Melanomas to hands, melanoma of the hands or feet, or melanomas that occur chronically sun damaged skin, such as lentigo maligna melanoma. So these will help you in remembering the mutation of the melanoma if they ask you the question that what mutation are common in melanoma. So like here, we discuss some of the mutation here above, so you can better remember this. Where would you examine this lady? So primary side, whole lower limb, including nail beds and soles. Metastatic side, chest, abdomen, and brain. So if you look at the scenario, so the scenario says that okay, so if you look at the skin lesion, you are given a pathology report. Report shows epidermis and dermis. So that is proliferation of the typical non-pigmented epithelial melanocyte at the junction of NVT. Okay, so they haven't mentioned the site of the body at which like skin. So remember always that you have to assess the the primary sites of whole lower limb if it's at the lower limb or inguinal. Okay, so the scenario for this question is this one. A patient known to have hypothyroidism with a hot swelling in her right inguinal region. Her GP sent her for biopsy. So this right inguinal region, so for right inguinal region, so you have to whole lower limb, including nail beds and sole assessment, and then chest, abdomen, and brain for metastasis. FNSC was done but not satisfactory. Why? Because not enough sample was taken, no information about the basement and given, only cells are obtained without a tissue background and not image guided, and it was a faulty technique, and that's why it's not enough. How would you treat this lady? Excision of the primary lesion. How would you treat this lady? So I will do excision of the primary lesion with the safety margin plus block inguinal lymph node dissection plus radiotherapy. Vemurafenib. Vemurafenib if positive for BRAF gene mutation. A lesion under the toenail was found, and the decision to amputate the toe and excise the lymph nodes were made. What's the objective behind this? Prevent local spreading of the tumor, control invasion, proper safety margin, and prevent recurrence. Post-operative, the wound is red and swollen. Culture was done to reveal the diplococci. Example of gram-negative diplococci are Neisseria species and Moraxella catarrhalis. Neisseria species and Moraxella catarrhalis, and diplococci are also the gram-positive staphylococci and streptococci. Example of gram-positive. Okay, so the above is the gram-negative diplococci. So gram-negative diplococci are Neisseria species and Moraxella catarrhalis. And gram-positive species, as I said, gram-positive diplococci or Staphylococcus aureus and Streptococcus pneumonia and Enterococcus. Next, the patient got toxemia with rapidly spreading infection. What do you think? Necrotizing fasciitis and diabetic. What is SIRS? So SIRS is a systemic inflammatory response syndrome, and this occurs when there are two or more than two criteria are satisfied. For example, the temperature is less than 38 or greater than 38. WBC count is less than 4,000 or greater than 12,000 or 16 or 15,000, you can say. And respiratory rate is greater than 20, and the heart rate is greater than 100. So all these will lead to systemic inflammatory response syndrome, and when there is infection with it, so it will be sepsis, and sepsis with hypotension will be septic shock.